The goals of RA treatment are to control inflammation as tightly as possible while avoiding side effects. When someone is first diagnosed or someone has a very bad rheumatoid arthritis flare and we need to stop it as quickly as possible, we may give a dose of steroids. We may also give non-steroidal anti-inflammatories or NSAIDs, things that you might be able to buy over the counter. Steroids are great at stopping inflammation quickly, but they have many side effects over time. Problems with cardiovascular disease or the problems with bone health can worsen with steroids, and we try not to have the patients on those drugs for any longer than we have to. And then the mainstay of treatment over time are disease-modifying anti-arthritic drugs, or DMARDs. Disease-modifying agents take a little while longer to affect the patient, so maybe a month or two before we see some impact, but they last longer and they, again, change the course of disease. There are a number of different kinds of DMARDs. There are the older ones that are the non-biologics, which essentially mean that they affect the white blood cells, but in no tailored way specifically. The non-biologic DMARDs are usually oral medications. The most common one that we use is methotrexate, and methotrexate can be taken once a week. Now, the newer drugs are the biologic drugs. Biologics are different than other forms of DMARDs because they're very targeted. They affect chemicals that are specific to the immune response, and sometimes even specific to certain cells in the immune system. So we know that we're really affecting the immune system and we're not affecting the rest of the body as much. One of the first-line biologics that we use are tumor necrosis factor inhibitors, or TNF inhibitors, and that's because they've been around the longest and many patients will respond to them. If the patient is not responding over time, we might switch to a different one of our drugs. There are a number of different biologics, and how we determine what biologic is right for which patient has to do with several factors. The first is patient preference and convenience. We also take in consideration the other disease processes that the patient might have. And then we try to tailor it to the response of the patient. Biologics have changed the whole landscape of rheumatoid arthritis therapy. Before we had anything to modify the disease progression, patients would end up having permanent deformities, end up needing surgery at very high rates. But now that we can prevent that damage in the first place, patients are not needing to go to those extremes.